Good evening. How's everybody doing? My name is Ramon Manning. I'm the board chairman here at Emancipation Conservancy. I want to take this opportunity to welcome all of you to Emancipation Park. You know, we've had a bevy of panel discussions to celebrate our sesquicentennial, and you know, I was just talking to Dr. Jeter and Dr. Hotez and Dr. Porsa out back, and you know, Emancipation Park, for those of you who don't know, was founded in 1872 by former enslaved African Americans. It was led by 4 gentlemen, Reverend Jack Yates, Elias Dibble, Richard Allan, Richard Brock, but very much like the civil rights movement, where you always hear about, you know, Dr. King, Dr. Abernathy, and others. There were also women who played a very important role to come up with the $800 to purchase this original 10 acres of land back in 1872. And so there's been a lot of talk about parks and green space and quality of life, you know, but I'm really proud of Emancipation Park because it's not just a traditional park through a recreational lens. These community leaders back in 1872 purchased this land right out of enslavement because they couldn't go anywhere else. And they purchased this land to be the foundation and the building block of starting to build a community. And as you think about parks and you think about Emancipation Park, don't think about this place through a recreational lens. Think about this place as an asset that was used and is still being used to service a community. And here, I'm just excited about this lineup of panelists. I won't steal Dr. Muhammad's thunder. I'll allow him to introduce these great panelists, but one of our core programmatic pillars here at Emancipation Park is health. And we chose that to be one of the core programmatic pillars because, again, as an asset to serve the community, when you look at 77004, 77021, there's no denying the issues around healthcare. In fact, those 2 zip codes are some of the highest uninsured and with the largest social determinants of health. I mean, it's just off the charts, it's astronomical. And we felt like in this celebratory moment, celebrating 150 years, it made a lot of sense to really have programs and discussions around these very important topics that affect this community disproportionately. So I'm honored to have, you know, these stalwarts come and talk about this, and I'm going to shut up here in a second, but I just want to leave this with you guys, is that, you know, Juneteenth is something very, very special. It's something that we need to really think about as a country and understand our past and our history and where we need to go, but not just look at it through a celebratory lens. I've been quite frustrated here lately because I've been seeing the commercialization of this momentous occasion. And for me personally, you know, sometimes they say you can be a little too close to something. You know, I'm a proud graduate of Texas Southern. I've been living in 3rd Ward for a long time, and this stuff is right up close and personal. And so for me, we want to be unapologetic and deliberate about the programming and the activities to not only honor the founders, but again, really service this community and try to fill these voids that are needed in this community. And so with that, I just want to say again, welcome. I'm glad all of you are here. This will not be the last health discussion we will have, but we just felt like in this moment with COVID disproportionately affecting communities of color, it made a lot of sense to really have this discussion today here at Emancipation Park. And without further ado, I would like to introduce to you all our interim executive director, Dr. Muhammad. Thank you all for being here.
Good afternoon, everyone. Thank you for being here. My name is Dr. Mohammed Abdul Rashid. I'm the interim executive director here at Emancipation Park Conservancy. I'm here to introduce our moderator for this evening, someone that many of you are quite familiar seeing on the 6 o'clock news. So Mia Greggy is the native Houstonian, is an Emmy award-winning talent in the 5, 6, and 10 p.m. theater at KHOU 11 News in Houston, Texas. For 2 decades, Mia has covered everything from historic hurricanes to major Hollywood red carpet events and national sports championships. She specializes in breaking news, continuous coverage, and special events with interest in women, empowerment, job readiness, health and wellness, and sports entertainment. She's also host and producer of the news documentary special, Juneteenth, 1865 to 2022. Mia is a proud alum of Sam Houston State University with a degree in radio, television, and specialty track in broadcast news. In 2016, the university honored and inducted her into its Distinguished Alumni Society. She is also a past inductee into the school's Dan Bradford Hall of Fame. Some of her other proud accomplishments and positions include co-founding Women of Wardrobe, Dress for Success Houston's Young Professionals Group. She's also a continuing education instructor for Dress for Success Houston's client-based professional women's group and an advisory council member for the nonprofit organization that Suits Up Women for Success. Everyone, please help me give a warm welcome to Ms. Mia Grady, our moderator for this evening.
Hello there, and good evening, everyone. I'm just going to take this off if I can. There we go. Hello, and good evening, everyone. So good to see you all here in person. I always get embarrassed when they read these bios. I'm a native. I feel like I know all of you, right? Do we really need to hear all of that? We know each other. We are family, we are neighbors, and we are friends. I'm so happy to be here this evening and lead this very important discussion talking about COVID and the community, and especially communities of color, communities that faced health disparities way before COVID came along. I want to talk about where we are today, where we've been, and where we're going, where we're moving with COVID in our community and how to deal with it, and also addressing some of those other health disparities and what that looks like now as well. We have this robust panel here with us this evening. I'm so honored to be in the presence of our wonderful distinguished panelists, including Dr. Esmaeil Porsa, CEO of the Harris Health System, as well as Dr. Erica Savage-Jeter, Chief Clinical Innovation Officer for Cinderwell Primary Care, and Dr. Peter Hotez, leading COVID expert and Dean of the National School of Tropical Medicine at Baylor College of Medicine. Can you please give them all a round of applause? All are here to discuss the impact of COVID-19 on our community. So let's dive right in. And Dr. Porsa, I have to ask you, where is Harris County? Are infection rates looking like? I know I'm reporting, I feel like every other day now in the news, that they are on the rise again.
They are. First of all, good evening, everyone. Thank you for being here, and thank you for inviting me. It's an honor to be sharing this evening with all of you. You're right. The numbers are on the rise. What is different this time around, I think it's very important to mention, is that this is not the surge like the surges that we had seen previously in the last couple of years. This seems to be a kind of a slow churn, up-sloping, very slow-moving surge of COVID, which I think is kind of to be expected when you think about the evolution of COVID-19. I'm sure Dr. Hotez is going to shed light on this. But with the current variant of Omicron being as contagious as it is, it seems like two things. One, the fatigue among everybody in the community and also among the healthcare staff, us letting our guards down, last couple of years being really strict about wearing face masks and doing all the things that we did, and also the fact that the Omicron is a lot more contagious than the previous variants, it makes sense that we continue to struggle with yet another very slow moving COVID surge. But yes, to your question, the numbers are rising. I think what we hear in the news and what we see in our hospitals is really the tip of the iceberg. I think a much better measure is the sewer water measurements of the virus water burden. But you look at it, and you can see the tremendous increase week over week of the viral load in this community. But again, the blessing, if there is such a thing, is the fact that the Omicron does not seem to be as pathogenic as the Delta and higher variants.
As severe.
As severe.
Right, right. And do we have any way of telling what this slow surge in infection rates looks like in different communities, mainly, let's say, the Black community?
Unfortunately, it's exactly what we observed previously. I don't think it's lost on anyone. That the COVID-19, a lot of people say that it created disparities. I think it shed a light on the disparities that have already existed in our societies. I can't imagine something else in the recent history that highlighted the underlying inequities that exist in our communities and the health disparities that are resulting from it, as well as COVID did. If anything, I think it was really a wake-up call for all of us to,
Yes.
I'm sorry, okay, I thought this was on, okay. Just to highlight the disparities that exist, and you heard that the calls into action, I think at the beginning of this conversation, that to honor, if nothing else, tonight here at the Emancipation Park, the founding fathers of this park, to honor them and take steps into addressing some of those disparities that exist and those inequities that exist among our communities of color. I've said that before, and I'm saying it now, that we talk a lot about inequalities and disparities. The systemic disparities that we're all witnessing, it's really, unfortunately, nothing more than, I'm going to say it's systemic racism that has continued to exist in our country. And for us to get over it, we just need to say it, acknowledge it, and so that we can cope with it.
So I want to talk about, we're seeing the surge, right? And we find that data in the wastewater, but I think something that seems to hit home with people in all communities is when our hospitals are burdened. Any idea what the hospitalization rate looks like right now as well, too, in the county?
Sure. So I think you all can hear me better now. All right, wonderful. Thank you. So yes, so the rate of hospitalization with COVID is up. I can tell you, just a month ago, I was celebrating the fact that one of my hospitals, Harris Health System has 2 hospitals, LBJ and Delta. LBJ had 0 COVID patients for 6 hours. It was still a momentous occasion because it was the first time over the last more than 3 years. It didn't last, but this morning we had 24 patients. Yes, that's worrisome, but again, if there is a blessing, it's the fact that the majority of the people who are in the hospital, in my hospital, and the hospitals in this area are not in the hospital because of COVID. They are in the hospital with something, but they also happen to have COVID, which is very different than previously. I'm really thankful to all the hospitals in this area that are continuing to test everybody who gets admitted to our hospitals. So we have this ability to discern this fact. I can tell you some hospitals in other areas are not doing this. So I want Harris County and the city of Houston to be proud of the fact that our hospitals are continuing to do this.
And what about in the county? We've talked about the rate of infection, hospitalizations. We have to touch on the death or mortality rate of COVID. Where are we now?
So much better. So I can tell you in our system, this is not the data that is widely available, but I can tell you that in Harris Health System over the last 2 months, we have had 2 COVID-related deaths. Previous to this current situation. Unfortunately, every day we had a handful of people who were dying of COVID. So very, very different picture, and much, much better picture. Unfortunately, the situation still persists that people are dying because of COVID, but at a much lower rate.
Thank you for that update and an overview of where we stand in the county. We want to dive in deeper about the disparities in communities of color, but first, I want to talk about in understanding where we are with COVID. We need to understand what COVID looks like right now. And Dr. Hotez, I want to direct these questions toward you. How has COVID changed from today to, at the height of it, the scariest time during COVID, when we saw mass hospitalizations and deaths reported widely?
Yeah, and thanks so much for having me. And we, of course, have seen COVID-19 work in big peaks and big valleys, right? It's pretty, when it goes bad very quickly, and then it starts to plummet. And where we're at right now is we have just finished a pretty terrible Omicron wave, which was very highly transmissible. Now it's reaching a nadir, a low point. But I think we have to be concerned about what we're seeing up in the Northeast. And that is they went through the net wave of these what's called subvariants, the BA2, 1, 2, BA4, BA5. I know your eyes start to glaze over.
It is a lot.
And the numbers, they should have their own Greek letter, but and that's what we've seen in the Northeast. I think we're seeing the beginning of that now in Harris County, based on the wastewater numbers that you mentioned. The hospitalizations are starting to go up, and the cases are starting to go up. The problem is, even at the best of times, when we estimated the number of new cases a day, that was an underestimate by a factor of 4 or 5. So you had to do a mental calculation in your head, multiply every number times 4 or 5. Now it's much worse because everyone's doing home testing. So the real number is maybe 10 or 20 times higher. So we have to be really careful about being complacent. Those numbers are starting to go up, but we can get caught off guard because the vast majority of cases are not being reported either to the state or, of course, to the Centers for Disease Control. So I am concerned. There's a lot of complacency. People think, well, I had Omicron in December, January, I'm probably okay. It doesn't look that way. It looks like Omicron, because it replicates mostly in the upper respiratory system more than deep down in the lungs. It's not protecting you against reinfection. So if you had Omicron but have not taken the time to get vaccinated on top of that, you're highly susceptible to reinfection now with these new subvariants, BA2, 1, 2, BA4, BA5. I think that's one piece. The second is, for reasons that we don't quite understand, these new subvariants are more resistant to the vaccine than the previous one. So if you got 2 doses of the vaccine, you were well protected against Delta. But if you only got 2 doses of the vaccine, either because of waning immunity, because you had it last year, or because of these new subvariants, you're still susceptible to hospitalization. So for instance, during Delta and Omicron, 85% of the people hospitalized were unvaccinated. Now it's not as high, because if you've only gotten those 2 doses, you're still susceptible. So what does that mean? It means pretty much the answer is the same every time. If you've not been vaccinated and all you've gotten is Omicron, you're susceptible, get vaccinated. If you've only gotten 2 doses of the vaccine, I know the Centers for Disease Control is calling that fully vaccinated. I fight with them every day on this. You're not. You need to get that booster. So make certain that you're up to date with that 3rd immunization.
Can we clarify, because I even get those questions as a journalist, how many shots should we have for the best protection right now? Walk us through what we should have.
What you should have is, if you're more than 4 or 5 months out of your last shot, you're susceptible. The easiest way to think about it, if you're more than 4 or 5 months out of your last immunization, you're susceptible to reinfection. Or susceptible to infection. So if you've gotten 2 doses last year and you haven't gotten your 3rd dose, get it now. Even if you've gotten your 3rd dose, but you're more than 4 or 5 months out of your 3rd dose, and you're eligible, get your 2nd dose, 2nd booster, meaning your 4th shot. So, for instance, I have 4 immunizations, and unfortunately the boosters are not holding up as well as we'd like. They're still good, but not as great as they were. So if you're, for instance, more than 4 or 5 months out of your 3rd immunization even, your protection against hospitalization is around 78%. Your protection against an emergency room visit is 66%. Still good, but not as good as it was. So you want to get that 4th immunization. The problem is the country's not buying it. The country's not listening, because if you look at nationally, only 100 million Americans have gotten their 3rd immunization, meaning 30% of the US population. How many of you have got your second booster, your 4th immunization? Yeah, how about the only one, right? And maybe a couple of others. So we're underachieving there. The bottom line is get it, because we are seeing that waning immunity. And it's still giving you some level of protection, but not as good as it was. So we're underachieving profoundly in terms of getting that 2nd booster.
Dr. Jeter, how are patients doing? When they come in, have they had the vaccinations? Are we hearing in that patient-doctor setting, okay, you had your vaccinations, now you need the booster? What is the conversation like amid patients with their doctors?
Good evening, can you hear me okay? Awesome. Thank you all for the invitation. But to answer your question, it's mixed. It really depends on the patient that you're talking to. A lot of times it depends on the demographic of the patient that you're speaking with. Some of our more fluid patients, they've had their 2 doses, they've had their 3rd booster, some of them have their 4th booster, but we have some minority patients that haven't been vaccinated at all. And so the conversation can be very different based on the demographic of the patient.
And with some of those minority patients, what is the hesitancy there to get a vaccination to begin with? Still, after what appears to be a lot of education that's been put out, a lot of calls to get this done, not just for yourself, but for your loved ones and your greater community as well.
So I think probably one of the biggest drivers still is fear. Not fear of the disease, but fear of the vaccine, a mistrust in the science. And so it's really a constant discussion around trusting, our healthcare system, the recommendations we have for the management of this pandemic, as well as other chronic diseases. It's really around that. It's not the education, it's around the mistrust.
I'm curious to know, has COVID resulted in people attempting to be more health conscious? Meaning, we've heard so much about the different impacts that COVID can have on someone who's once stricken with it, right? If you are in bad health to begin with, you're already dealing with health challenges. Have you heard from any patients about them changing their own attitudes about health in general, and how important of a role does that play in the fight against the virus along with being vaccinated?
I don't think I've met many patients that weren't concerned about their overall health or had desires to be more healthy. Most of the patients that I interact with have barriers to that. And so my work with Lovell, as well as my other colleagues, is really designed to help them eliminate those barriers. They have the desire, they may not have the resources, they may not have the know-how, and so we work together to try to eliminate that. But broadly speaking, a patient that takes the time to come in, to engage with their primary care physician, they want to be healthy. They want to live healthier lives. A lot of times it's just, how do we get there? What do we need to access? What barriers do we need to remove?
I think often people want to be at their best, but then life happens, unfortunately. Things like diabetes and high blood pressure. Those are all health challenges that we find in the African American community. And that goes back to some of the health disparities that we widely discuss. How does that play a role in it? Just the health disparities for this particular sector of the population?
Well, we know that, certain medical conditions, chronic conditions, increase in patients' risk of having unfavorable outcomes as it relates to COVID-19. And so because we see, a greater incidence of prevalence of diabetes and hypertension, chronic lung disease, chronic kidney disease among minority groups, of course, and that those groups are at risk for the unfavorable outcomes for COVID-19. So, a lot of it is around having those discussions and helping patients understand that. And really, we work at Central to, risk stratify our patients, to have those patients with those medical conditions really have conversations, moments where we talk about those things and make sure they understand their risk and everything they can do to mitigate their risk, whether it's vaccines or whether it's not becoming complacent and still continuing to mask despite having a vaccine, and all those things all those safety measures that we've been using for 2 years to try to keep everyone safe.
Talking about those preventative measures, and Dr. Hotez touched on this earlier, there are people who are getting reinfected. Is that commonplace in the clinic setting? Are you seeing people who've had COVID twice, maybe even 3 times?
Absolutely, and just as you mentioned, a lot of people are testing at home, may or may not disclose that information. Some people are avoiding testing altogether, but yes, we are seeing patients that are testing positive again since this, having the infection initially and are testing again positive.
Do you think when we talk about the disparities in the African American community, you think about the challenges that are within those communities, and oftentimes it comes back to finances. Is that something that hinders people, be it COVID or something else in their own health that is a barrier for them in seeking healthcare and getting healthcare, the cost of it?
Absolutely. When COVID was, had its initial surge, a lot of the work we did in Central revolved around telemedicine. So we shifted so that we could make sure our patients would have access to us without increasing their risk of exposure. But what we found out, a lot of our senior patients didn't have devices to connect virtually. Some of them were in neighborhoods that didn't have broadband internet service. And so the lack of those resources prevented them from engaging with us virtually. And so they would still, of course, come into the center. But just something like that where we thought that by doing this, we would increase access. There were certain populations of patients that it didn't do what we wished because they didn't have the resources for it. And it comes back to those economics, those financial resources.
Do you think that COVID has exposed more of these disparities within communities of color?
I think for those of us that have been in communities of color, we were aware. We knew. I think it exposed it on more of a national level. I think that it became the topic of discussion for more people. But we've seen disparities for a long time and a lot of chronic illnesses like diabetes, like hypertension, like cancer. So it's been present, but I do think that COVID-19 caused it to be discussed by many more people.
I think one of the challenges in communities of color, and especially where there are financial challenges as well, compounded matters. It also makes it hard when you're sick, but if I don't go to work, I don't get paid. That presents a barrier as well.
Absolutely. And as we think about COVID-19, we think about all the essential workers, majority of a good number of those were minority individuals. And so that caused exactly what you described, right? There's a risk for going to work because there's a risk I may be exposed to COVID-19, but I have to, I have financial obligations, I have to feed my family. And so a lot of times people just had to make that choice and
I know that in the greater community, Dr. Porsa, maybe you can speak to this, that we're hearing about more cases of RSV. It seems like, I don't know about everyone, but friends and family that have some type of upper respiratory something going on. Those seem to be on the rise as well too. How challenging does that make trying to keep COVID cases down? Because now people are also self-diagnosing, oh, because my coworker also had an upper respiratory something, oh, I think I have the same thing.
It is challenging, and you're right. There are 2 points to the question you just asked. As far as the number of RSV cases going up, it really goes back to the conversation we're having earlier today that because of COVID, people changed their health habits. At least a large portion of our communities changed their health habits. Social distancing, wearing face masks, washing your hands. And a couple of years ago, we had almost no flu cases. I mean, that was not by chance. It happened because of the habits that we all exhibited. And then last year, we had more flu, but it's still a very light flu season because, again, we continued doing what we were doing. And yes, the cases are on the rise, but are on the rise compared to what had happened the last couple of years. So that's point number 1. Point number 2, and you're absolutely right. I know folks, and you heard just now that people are not getting tested because they are contributing their symptoms to, I just have allergies. I just have a cold.
That seems to be the most common one, right? Oh, it's just my allergies.
Especially in Houston, Texas, right? So all those are going on, but I wanted to go back to something that we just talked about. I wanted to comment on it about the COVID-19 and the health disparities. I think it's true that the health disparities, folks in this room, I think everybody was aware of it. But I think COVID-19 not only shone a light on it, I think it changed the conversation. In the sense that we are no longer, at least in my sphere, we're no longer talking about the African American, the Black population, the Hispanic population. They have diabetes or they have hypertension, they have cancer because they're Black, because they're Hispanic. That is no longer the conversation. The conversation is that the Black and the Hispanic populations have higher rates of hypertension and diabetes and cancer because of the social inequalities that have existed and has been directed towards them. This is not a genetic issue, this is a social issue. And I think that conversation has changed, which I'm glad, because in reality, that's exactly what we're talking about.
So now that we know that there is an issue and that it is more widespread and not just this community that knows about it, what are the next steps that have to happen to try and make it more equal? And I know, right, we're trying to solve the world's problems here this evening, but what would be maybe even some first steps?
I think conversations like this are the first step. I think people feeling empowered by knowing the truth and not just asking but demanding change is what's going to take for us to get past this. I know it's a very, very slow process. It's not going to happen overnight, but it has to start somewhere. And one of the things, and I've always said this about COVID-19, is that it has been a miserable, miserable disease. It has been a terrible thing that has been imposed on our societies. But I always consider myself a pathological optimist as well, and always look for the silver lining. The silver lining to COVID-19 is that we are having these conversations. The silver lining is that we are aware of the impact of the health disparities on our communities that historically has existed, but has never percolated to the top of our conversations, and now we're having those conversations.
Did you want to piggyback on that?
Yeah, I can appreciate your optimism. But we've been having this very conversations for a while, and before COVID-19. And a lot of us have been a part of those conversations. I'm optimistic as well, but we have a lot of work to do.
I mean, the numbers speak for themselves. If you're Black or Hispanic, during this pandemic, you had a 1.7 times risk of dying from COVID compared to non-Hispanic whites, and you have a 2.2 times risk of being hospitalized. And the reasons for this we've talked about are the fact that if you're living in a low-income community, you're not working from home on Zoom, right? You're out in the community on construction sites and family-owned businesses, and then the underlying comorbidities associated with it. And the sad part was we knew this was coming and really didn't do a lot to stop it, and including here in Houston. I mean, look at the Texas Medical Center where I work. It's the most sophisticated, advanced medical center God ever created. And yet our community of Houston has some of the worst health indices of any major U.S. cities. And so to your point, we have to be realistic and is COVID-19 going to be a wake-up call to fix it? I like to think so, but you're still struggling, right, to double the size of Benton Hospital and to double the size of LBJ Hospital. It's a constant battle in putting in community clinics. So it's so important to do this, but it's been so long.
I'm always about finding solutions or next steps. So, because that was a downer, right? I mean, no, I'm just saying, being a realist, it sounds as though we've been having this conversation, and there's one audience that lives this. So what do we do? Does that have to be some type of governmental change? I mean, does it have to come at that level? Or is it a matter of us going into the doctor and asking for more and expecting more? And no, it really does hurt. Or maybe I do need to get a second opinion, but we're also talking about people who don't have the resources, right? I finally got to the doctor, I can't take off of work. I mean, what can we realistically do? First steps, potentially even?
I think if I speak on behalf of the organization I work for, Centerwell, I think Primary Care, I think, our goal, and this probably will help transform some of this, our goal is really around the health and wellness of our patients. And so a lot of the work that we do really is not all about the management of chronic disease, but it's also around preventative and early screening and early disease detection. That's where most of our work is. And so it's in that change that we find that we're able to diagnose patients sooner. We're able to work with our care team that includes our docs, our nurse practitioners, social workers, pharmacists, all of us working collaboratively to help our patients. And what we see are healthy days for our patients compared to patients that are being cared for outside of organizations like ours. And so I think we have to change how we execute or how we deliver healthcare and really start to become more oriented in outcomes and trying to prevent unfavorable outcomes and improve the healthy days of our patients. Our goal is to keep our patients home healthy. I'm sorry, out of the hospital. That's our goal.
He was celebrating having, what did you say? You had no COVID patients for 6 hours, so he was celebrating it.
I think there are things that seem insurmountable, and there are things that are more straightforward. So, in the insurmountable category, my friend and colleague Allison Galvani, who's a mathematical modeler at Yale School of Public Health, has said, if we had a single-party payer system like the UK or Israel, we would have saved 300,000 lives during this COVID-19 pandemic. Or as I sometimes say in my frustration, the UK and Israel have a health system. We have something called Amazon Pharmacy. So that's in the insurmountable category. Congress is so heavily lobbied, keeping the status quo. I think that's a frustration. But there are less lofty things that we can do. My friend, my colleague, Dr. Blackstock, points out that 40 years ago, 2.3% of all physicians were African American. What's the percentage now? I think it's 2.3. It hasn't
Yeah.
changed, right? So what are we doing here in Houston to increase people of color among our medical student population? The new University of Houston Medical School is trying to make that effort. Why aren't we building a medical academy with Texas Southern, for instance, in Prairie View, in our Texas Medical Center to really roll up our sleeves and make that happen? And you know, everyone, we're moving towards it, but it's very incremental, very slow. And I think we do have opportunities to do something that's more game-changing.
It's a start, and that sounds like a good start. Definitely leaning more toward the optimistic side now as well too. I want to bring us full circle because the reason why we're here tonight is COVID. And we talked about preventative medicine, right, in general. But is that what we need to perhaps return to? And is that the key here with COVID and where we are now? And I want to talk about this summer, because it seems like with summertime too, we've seen those surges and those peaks.
Okay. The easy, quick answer is yes. We need to do that to stop the surge, or at least blunt it to the extent that we can. But I want to go back to the question that we asked previously. It was intriguing when you said, to go to the doctor and be more forceful and say, it hurts. You know, going back to this whole idea of hospitals and health systems and disease systems, the way I describe it, that in this room, when we say healthcare, automatically, I'm sure, majority of us, if not all of us, imagine a hospital, imagine a clinic, imagine a doctor, imagine a nurse, imagine a CT scanner, an MRI. The truth of the matter is that healthcare has very little to do with any of the stuff that I just said. In reality, healthcare, and I just heard it for the preventive care, healthcare is social care. So what we need to do, you said, where do we go from here? We change the mindset that healthcare is not about more hospitals, and I can say that as the CEO of the hospital, I always describe hospitals as necessary people. We need hospitals to take care of the heart attacks and the strokes and the appendicitis and the trauma. But healthcare has nothing to do with hospitals and doctors and nurses. Healthcare has to do with how we take care of ourselves as a community, socially. The air that we breathe, the water that we drink, the food that we eat, all of those things. And yes, that's also the answer to COVID. There is a reason why African American, the Black population of the Hispanics had more than twice the likelihood to be hospitalized due to COVID. It was not genetic. It was because they were suffering from a poor health status to begin with that caused this. That happened because of a poor social situation that they found themselves in chronically. That's what we need to get at.
We're in the dog days of summer. We didn't hit 100 today. Can you believe that? It certainly felt like it.
Hallelujah.
I'd ask our meteorologist during the commercial break, are you sure? My car said 105. We know the cars, though, are different. I digress. But we're in summertime now. People, they just want to have a good time, right? They have barbecues and family reunions and these big get-togethers. What type of summer outcome are we potentially looking at when it comes to COVID infections?
It depends. How do we approach it, right? If you wash your hands, if you stay outdoors, if you wash your hands frequently, you stay out of visiting grandma and aunt and uncle if you're not feeling well, if you have quote-unquote allergies. Or if you just, blow caution to the wind and do what we all did, 3-4 years ago. We're going to have two different outcomes. We're going to have a summer that is going to usher a very, very bad fall and winter with regard to COVID, or we can just moderate the impact of COVID and enter the fall and the winter season in a much better situation.
Dr. Hotez, is COVID here to stay, and will it be with us? You mentioned earlier BA 1, 2, 3, 4, 5. Are we just going to keep seeing that evolution?
Well, I think first of all, just to dovetail on the last question, we've had a pretty bad peak here in Texas in the summer of 2020, July, August, September, and And Mother Nature gave it the same thing to us again in 2021, July, August, and September. I think we have to listen to her. I think we have to think about July, August, and September. So even if we get through this BA alphabet soup surge, the BA212, BA4, BA5, that will go down as we enter into July, I think. But I think we're vulnerable from another variant from abroad because we failed to vaccinate the world's low and middle income countries. So I think we should get ready for that. How long will this last? I was hoping 2022 wouldn't be as bad as 2021, and it's not, but it's still pretty bad. So I'm hoping that if we do a better job vaccinating the rest of the world, because that's what it depends on. I mean, Delta arose out of an unvaccinated population out of India last year. Omicron and BA2, BA4 arose out of an unvaccinated population out of Southern Africa. So until we have that commitment to vaccinate the world's low and middle income countries, this still could continue. I'm hoping, though, by next year we should be in a much better position. But we still have some rough waters ahead. I'm worried about July, August, and September here in Texas. Nationally, I'm worried about January, February. What happens after that? You know, the 1918 flu pandemic, we call it 1918, but it lasted until 2020, till 1922. So it was a 4-year pandemic. That's what this is probably looking like, 4 years. So hopefully it'll start to go down after that.
Seems like we've been living it for quite a while, so we'll continue to pray and vaccinate and boost. I think on that note, we're going to conclude our panel discussion here. Thank you all so much for your contributions and for all the forward as well. But thank you so much for attending this evening. We hope that you walk away enlightened and informed. Thank you.
So we're going to take this opportunity to open the floor for any questions as it relates to our panelists. Are there any questions from the floor?
Dr. Grace, that's not fair.
Well, thank you all so much for sharing your knowledge with us. So one of the things that we heard about is the notion of trust. And so we can see that on the right, there's an issue with trust in terms of, I don't want to take the vaccine because it's some sort of brave new world thing that's going to take over my brain. But then there's also the trust from the perspective of the African American experience where there is a history. And so I began to wonder, as much as we build things and we have systems, how do we get to the point where people don't feel though the system is trying to lead them astray and the system is trying to do them some good? How do we build that trust?
Dr. Grace,
I'm looking at you.
No, I think, to be completely honest, and, without being facetious, it's things like this. It's, you and I have had these conversations previously as well. And it's one thing for me as a CEO of Harris Health System to say that, we want to take the healthcare to the community. It's another to actually go to the community and partner with a trusted community presence to do exactly what you just said. Me speaking from Harris Health System is one thing, but if I'm here at Emancipation Park and we have a presence at Emancipation Park and we talk about health issues and health disparities at Emancipation Park, I think that's what's going to make a difference. It's really being in the community, partnering with trusted community entities for us to get there, because you're right. I can smile all I want, and I can say all the nice things that I want. As long as I'm not viewed as a member of the community, it's not going to have the impact that it needs to have.
Thank you.
So can I just add to that as well? And that's everything you said I agree with. There's another piece to this though as well, and that is what anti-vaccine activists and groups have been doing. They have been deliberately targeting African American groups in a very exploitative way. There's been a documentary, quote documentary going around, which basically shows people of color getting their Pfizer-BioNTech vaccine, and then it flips over to grainy images of Tuskegee experimentation in the 50s and 60s. It's exploitative as hell, and in my view, it's racist as well. And now they're making a second quote documentary called Infertility, trying to make the case that vaccines are being used to deliberately sterilize women of color. It's all nonsense. I'd use a more colorful word if we were talking one-on-one. But you get it. And so there's this, and we don't talk about this enough, because yes, there's historic distrust, but the truth is, when you look historically over the last 20 years of vaccination rates among people of color, they're pretty good. They've never really been that high. There's been some access issues and things like that. So I think we've underestimated the detrimental impact of this specific targeting by anti-vaccine activist groups who are doing a lot of damage.
Thank you. And Dr. Jeter, do you sense that being an African American and interfacing with African Americans, do you sense that there's greater trust from that perspective?
Well, I was going to add that, I think one of the ways to improve adherence among patient populations really revolves around their engagement and trust in their clinician. And so building the foundations of that relationship of patient and clinician will tend to lead to improvements in adherence to other things. So it's that engagement, that trust. And so because of that, I work really hard to build rapport and trust with my patients. And do they do everything I think they should do to maintain their health? No. But it is a conversation that we have, and it's really kind of a give and take and meeting them where they are. And because of that, I feel like I am able to a lot more of my patients were vaccinated because of that. A lot more of my patients, probably than some other clinicians, look like me because I'm African American, right? They come to me because I look like them, and that helps build that trust also.
Which also gets to train so few black physicians.
Exactly.
Especially black male physicians. I mean, they're just so rare now. We've got to fix that.
But that's even beyond African Americans, all my own groups.
I have a question, and I'm going to sit down. I think I can talk loud
We can hear
enough.
you.
Can you hear me? In talking about COVID, one of the concerns that I continued to have, and I had all along, was there was a lot of talk at the beginning from the government and everybody about how they were going to make sure that people of color and people in rural communities were going to have access to the vaccines, and that there was going to be kind of an equality there of people getting the vaccines. And somehow, as time went on, and if you paid attention to what was really happening, the people who are in those areas, many of them, not because they didn't want the vaccines, they still did not have access to getting the vaccines. And to me, that's, again, a real problem of inequality that not only happens all the time, as we spoke of earlier, but it happened again after it was brought up to the top of the surface that this was something we were not going to allow to happen, but it still happened anyway. So many people in rural areas and many people of color never got the vaccines, not because they didn't want them, but because they did not have access. And yet people of affluency and urban areas, many, the vaccines were readily available. How can that be addressed? Because a lot of those people are people who died because they did not have the access.
And we saw that at just about every level of this pandemic. Initially, it was very hard to get tested.
Right.
And then it was very hard to get vaccinated. Then it was very hard to get
Exactly.
monoclonal antibodies. So at every level of this pandemic, we've seen that happen.
I think there was a design flaw from the very beginning. You know, we all heard about Operation Warp Speed,
Right.
for producing the vaccines, and then we saw the Trump administration had put a 3-star general, 4-star general that was going to mobilize the military to actually get the vaccines out to the people. It turned out what that really meant was they were going to get the vaccines onto the back of the FedEx and the UPS trucks. That was the plan, and then it was adios, you know, after that. And there was never really a plan to, and then they said they were going to work with pharmacy chains, you know, Rite Aid and CVS and Walgreens, etc. But nobody ever figured out that low-income neighborhoods, those are pharmacy deserts, right? And there are no pharmacies there. So I think one of the things the Biden administration did make an earnest effort was to start trying to get vaccines in community centers and create the big venues around the stadiums. But I agree it wasn't adequate. So it was kind of a mid-course correction and trying to fix it. That's how I see it.
I just want to say that how absolutely astute your observation is, that it wasn't just in rural areas, even in urban areas, that discrimination still existed. You know, like Dr. Hotez just said, you know, something as simple as you know, we're talking about, how do we change this? We should become culturally competent and aware. I used this example earlier today that, you know, and for a lot of good reasons. The Harris County, the city created these, you know, mega vaccination centers for them to drive and get vaccinated. But guess what? The people who were being most impacted by COVID didn't have a car. They couldn't drive. They could not stand in line for 5, 6, 7 hours to get vaccinated. So again, all good reasons, all sincere efforts to get people vaccinated, but not a culturally competent and a culturally sensitive decision. To answer your question, what do we do? Hopefully learn from it. I can only hope that we learn from it.
I think also, you know, my impression is we just don't have a good health infrastructure. We have lousy health infrastructure to begin with for everything, but particularly for adult vaccinations. You know, when it comes to vaccinations, the big emphasis is on pediatric vaccinations, and that system is somewhat working. For adult vaccinations, we've never had a system in place, and that's why we've failed to get flu vaccines out, or Tdap, or some of our other vaccines, and that really, the COVID-19 really exposed them.
And I was just going to add, COVID-19 was a public health issue. It's not political. And I think that's the biggest thing we should learn from this, is that our approach to it should not have been dependent on the administration, because it's a public health issue.
So I have a question here from a public health perspective. What would be your recommendation for vaccinations? Are we going to start to treat COVID like we do the flu shot, where we have to get a biannual shot because of the waning immunity, or are there going to be vaccinations on the horizon that will last longer? Can you give us some context around what that potentially looks like as we move into the next few years?
Yeah, I mean, I have my own bias because I have our own COVID vaccine that's being used in India, Indonesia, and the African continent, but everywhere except the U.S. And that is, I'm a little concerned that the mRNA vaccines are not holding up as well as we'd like in terms of durability of protection. And how much of that is due to these new variants versus just the inherent design of the mRNA technology, I don't think we know. The problem is the American people are not accepting the boosters. Only 100 million have taken the first booster. I think just the people in this room have taken the second booster, and who's going to take a third or a fourth booster? The answer is they're not. So I've asked my administration to say, can we look outside the box and think about bringing in other technologies with full disclosure of conflict of interest here that, that includes recommending our vaccine as well. But I think we have to look at that because I just don't think people are going to accept boosters on an every 6-month basis. It's just not going to happen.
Any additional thoughts?
Nope.
I think we've got one more question, or 2 more questions.
Good evening. I actually have like 2 questions. The first one is, as COVID was on the rise, we also saw the rise of diversity, equity, and inclusion work, and what I think is super important, justice work. I would love to hear about the strategies that each of your organizations and companies are taking as healthcare industries, or as elements of healthcare industry to advance these things long term. My second question was focused on the long-term impacts of COVID. There's a lot of information coming out about it. What should we really be looking at in communities of color surrounding the impacts of long COVID, and what should we be doing to support individuals who will have those impacts as well? So 2 questions.
I'm sorry, I didn't hear your second question.
Okay, my second, sorry, I should have been closer to the mic. My second question was, we are beginning to hear about the long-term impacts of COVID and people that just will perpetually have symptoms. What are y'all hearing as healthcare professionals? And then what can we do for people in our community, for people we're close to that have these long-term impacts of COVID?
So I'll start. So first of all, thank you for not only saying diversity, equity, and inclusion, but then adding the justice part of it. I can tell you that we have not solved the problem. And maybe maybe that was but at least we are aware of the problem, right? Like I said previously, acknowledging that there is a problem is the first step. So we are having those conversations. We so we hired a person who is going to lead our diversity, equity, and inclusion activities, and we just actually created a department of diversity, equity, and inclusion. Not that that's going to solve the problem, but we are acknowledging the fact that we need help to become a more responsive organization with respect to diversity, equity, and inclusion. When we look at our numbers are not where they need to be. Our health system is not reflective of the community that we serve. We have to address that. And hopefully we're taking the first steps in getting to that. As far as the long COVID, the jury is out as to what is causing the long COVID. There's a lot of studies that are being done trying to figure out why people get it, why some people don't. Why is it more severe in some people and not in other people? But to answer your question, what can we do as community members is support the community members who are suffering from long COVID, acknowledging the fact that long COVID is real, and there are some people who suffer from it, until we figure out what causes it and how we can address it. That's the best answer I can come up with. But thank you for that question.
So for your first question, I am an associate employee of Humana, and I believe Humana to be one of the most diverse organizations that exists. I wish our inclusion and diversity Chief Medical Officer, Dr. O, was here to answer your question, because I'm sure she has a great answer in terms of all the work that's being done. But I know the organization to work very hard to develop diverse talent, and I'm an example of it. I'm sitting here today. In terms of your second question, from a primary care perspective, our goal is to prevent patients from getting COVID at all, right? So that's to answer your question, how do we want to prevent long COVID, or how do we prevent long COVID? We want to prevent patients from getting COVID to start. And then it becomes supportive for us. Our goal is to, whatever symptoms they're having, we're supporting them to improve their ability to perform their daily activity. So for us, it's about support. It's about prevention and then support.
So I'm very worried about our nation in terms of long COVID, given the number of people that have been infected with the virus. We've learned a lot about it in terms of mechanisms, and there are fascinating mechanisms around microglial cell activation in the brain and autoantibodies, but I'm particularly concerned about the neurologic consequences of long COVID. And we first learned about this from the Brits, because the Brits have, before the pandemic, they had a biobank of 40,000 MRIs, brain scans, and they were able to bring individuals back who had COVID-19 to compare before and after, and they're showing a lot of gray matter, brain degeneration, and evidence of cognitive decline. And I think this is going to haunt our nation for months, if not years, and it's going to really tax our mental health system. I mean, I don't have to tell people here, especially you, how awful our system of mental health care is in the United States, and this is really going to tax it in a big way, and we're not ready for it. We're not looking for it. We're not putting in place help for people with cognitive decline because of COVID-19, and the fact that when people get cognitive decline prematurely, guess what that causes? It causes something called depression, and so there's going to be yet another epidemic of depression in this country going on that we're totally not prepared for. That's what you notice. I don't get invited to parties.
Hi guys. I was wondering if you all could speak to what the numbers look like for children, and also if you think that down the line, having the COVID injection is going to be a part of the normal immunizations that we require kids to have for them to go to school.
I don't have the pediatric numbers because we actually don't have a pediatric board. Our response to pediatric patients who show up in our hospitals is actually transferred to children's hospitals because they can provide specialty services. Your other question was, what was the other question?
The immunizations, at some point.
Oh, that's like your Hotez. I'm not even going to try that.
Well, we are, so I'm trained in pediatric infectious disease, although I don't see patients any longer, but we have seen a lot of pediatric illness. We often tend to dismiss the severity of COVID-19 among kids, but I think it's real, especially during that Omicron wave. We saw a lot of pediatric hospitalizations, and also long COVID among kids as well. So I am extremely concerned about that. We are underperforming in terms of vaccinating kids. I think only about 29-30% of the 5 to 11-year-olds who are eligible have gotten their COVID-19 vaccines. Even among the 12 to 17-year-olds in this part of the country, we've underperformed. I don't think, this week we'll hear from the FDA Advisory Committee about approvals in the under 5s. I think even after it's approved, which will be at some point, very few parents are going to vaccinate their under 5s, just based on the fact that only 29 to 30% of the 5 to 11-year-olds. And then it only goes downhill from there, because what we're seeing now from the anti-vaccine groups, they're emboldened, they're empowered, they've got political power from the far right now to target COVID-19 vaccines. They're not going to fold the tent and go home after COVID-19's over. They are now targeting childhood immunizations in a big way. We had a big drop early in the pandemic because of the social disruption. Parents were bringing their kids to the pediatrician, slowly coming back to baseline. I'm pretty sure we're not going to come anything close to baseline because of all the anti-vaccine activism. So when you combine it with low pediatric rates of COVID vaccination to begin with, and the spillover of the anti-vaccine groups in COVID-19 to general childhood vaccinations, it's not, in my opinion, it's not looking great.
Thank
I
you.
take care of seniors, but I do have children, and my observance has been, when children, my kids' friends, that about a third of them have been vaccinated. vaccinated. And so, because we still haven't, a lot of people haven't understood this to be a public health issue, it's still a political issue. I don't see it becoming a part of the routine schedule, not right now anyway. But I wish it would.
Exactly, thank you.
Hi everyone, just a brief question. My name is Ashley Patterson. I'm actually a pediatrician too, so thank you all. I'm with Texas Children's actually. And I wanted to piggyback on her comment and also some of the things that you guys have said tonight is that yes, I agree, and I thank you all for saying that we need more diversity in healthcare because yes, just like Dr. Jeter says, just if we are just being there, providing some comfort to our patients and some trust just based on that. And just to kind of piggyback on the question that you asked, is I see even just being there helps sometimes, and just also being there with patients. Now, I had a mom that came in and told me she's gonna stop vaccinating her kids. And she already had 2 kids that were fully vaccinated, and it was a child that was 2 and was not gonna need any other vaccines for a long time. But I said, well, why are you telling me that you're not gonna vaccinate anymore? The kid's already pretty much vaccinated. What's happening? And it's because of COVID and the vaccine from COVID. She's afraid that they're gonna do something to the other vaccines, and all of this marketing is just, it's awful. So I'm in the trenches with you guys, and I appreciate you guys being here tonight and having this conversation. And I also wanted to ask a specific question to Dr. Hotez. Do you think that people under 50 should start getting that second booster shot also? Because I haven't gotten my second one yet, but I am 6 months out, and I'm not sure, I don't think it's routinely recommended just yet.
That's right, and it was everything we could do to persuade them to get to 50 and over. Personally, I think everyone should get their second booster. All adults should get their second booster, but that's not been the CDC recommendation yet. But if you can get it, I would say yes. I don't see a downside to it because, as I say, the boosters are not holding up quite as well as we want.
Okay, yeah, hopefully through our organization we can get the second one. And then I was gonna say, I'm glad to hear that hopefully the FDA will hopefully bring forward the one that's okay for under 5 now, because I do have patients that are asking for it, so I want to be like, yes, we can do it, but it's taking a while.
I think the parents who vaccinated their 5 to 11-year-olds, they're all in on the younger kids, if they have siblings. But again, we're looking at the tops, it's going to be 30%, unfortunately.
Well,
There's going to have to be a lot of advocacy and public service announcements about vaccinating the younger kids, but it'll start slowly.
Yes, and I think diversity in gender also is important too, because you said you have children, and so I think that helps too when you talk to parents about vaccinating their kids. I have kids, I vaccinated my kids, but anyhow, thank you.
Thank you.
Last question.
Not unless there's another lady. Right. Last question, 6-part question. Kidding. My name is Pastor Lou, and so I bring a different perspective, and that's one that affects the faith-based community, especially in the African American community. COVID and either the illicit marketing and the projection of it that was out there totally annihilated faith-based communities and the trust in worship and attending worship service, right? I guess at the very onset of COVID, you saw, especially in black churches, this wave of attack and illness that it projected. Well, that's still apparent today. I sit on several organizational boards within this community, and there are many churches and faith-based places of worship who have not yet recovered because still the membership, if you will, doesn't have that lack of trust. And
So not recovered in terms of attendance in church, or not recovered in
attendance in church because of the fear. I pastor the Antioch Church downtown. I'm proud to say we have about a 99% vaccination rate, even on the booster. I've got a healthcare background where education is the key for me. And so we are still working through that at our church. But I guess my question is, in that space, in that faith-based space, outside of the things that we're doing typically on the outside, because we like to congregate, and I get remote work, and now there's this new thing that called remote worship, right? And so it's affecting, and this spread of this illicit information is I believe having a serious impact in this segment, in this space, right? We've partnered with the City Health Department and Texas Children's to provide town halls to our members in the community, but that doesn't seem like that's enough. And so when we talk about mistrust, speaking in this space, I think it has really, really hit us very hard, especially in the Black community. One of the questions that I get all the time is that the Johnson & Johnson vaccine, right, was taunted as the one-shot wonder. And now you hear the effects that it's having with several people. And you've got a Johnson & Johnson. What shot do you take, coming off of a Johnson & Johnson if that's not the good one? And do you guys recommend that shot moving forward in terms of getting boosted? So there's a lot of fear still, and I'd like to hear your comment on education and how key education is, because I thought I heard it's not the education or something like that, and I didn't want to walk out misunderstanding the statement, but in this space it's really hitting us hard. So
It's not just education.
No, I understand.
Education still is an important component, but it's not just education.
I understand.
I think, and I can only speak from my perspective as it relates to church and faith-based organization. I think people have to feel a sense of security. And, I can remember early on when we went to virtual service because of COVID, and then people got complacent and enjoyed staying at home, right? And they had every excuse not to come back until the sanctuary. And so we were very intentional about all of the safety measures, 6 feet apart, marking pews, taking temperatures at the door, requiring masks. And then when vaccinations rolled out, we had vaccination enrollment drives where we called our congregants who were 65 and older, and we registered them for the vaccine. And when we started coming back in person, we were intentional about communicating what we were doing to prevent spread, how we were cleaning the church, all the things that we were doing to build that confidence, that trust. It didn't happen overnight. It took people, sometimes people enjoy bedside Baptists.
Sure.
But we just, the message, we continued the message. If you have a healthcare professional, you said you have a healthcare background, but
we started I started a COVID task force at our church, and so we did the same things that you did. But there, and these churches, your church sounds like my church, are the one-offs, right? Yeah, because there are a lot of churches in this very community who are, because of this, it's really hurting.
By the way, I think you did a lot of good, and I say that because when you looked at the people who said there was no way they were going to take a vaccine, the 2 highest groups were those who were watching Tucker Carlson and Fox News at night. That was group number 1. Group number 2 is the African American community. The vaccine hesitancy among the African American community went way down. It's still not where we want to be, but it really improved. And I went on a Zoom call with one of the Black churches in Richmond, Virginia, and the pastor was on, and I was asking him, what do you think's going on? Vaccine hesitancy went down, and more people of color are accepting the vaccines. He said, well, part of it's docs like you, and I appreciate that. But he offered it was the clergy. And there was kind of an informal network of clergy members that said, we're not going to put up with this. And I think you guys are the unsung heroes.
Well, and to that point, and guys, this is my last
and
point.
I think you saved a lot of lives.
Well, we talk about putting vaccines in CVS's and the community centers. My point is, there's a church in this community just about everywhere. And if we can partner with the health community, I think that's a huge step, right? We service downtown Houston Antioch Church is 156 years old, the oldest African American in this city church, right? Plug, plug. But if we can partner with healthcare, and I believe that that combination is a sweet spot that I think that we've really investigated further enough. And as I take my seat, as we say in church,
But I want to go on record by thanking you.
No, deeply grateful. J&J vaccine, could you speak to that and taking the next
Yeah, very
poster,
quickly.
please?
So there was a couple of problems. Problem number one was the Centers for Disease Control did not do a very good job measuring vaccine effectiveness. So we depended on Israel and the UK for our vaccine effectiveness numbers. They had the Pfizer mRNA vaccine, so everybody who got the Pfizer vaccine learned how effective that vaccine was. The Moderna vaccine they extrapolated from the Pfizer, but the J&J vaccine, there was no information forthcoming. So I think there was a lot of buyer's remorse because of that, because people who got the J&J vaccine, hey, how come I'm not hearing anything about the J&J vaccine? That was problem number one. Problem number two was it was always a 2-dose vaccine. It should never have been pitched as a 1-dose vaccine. And I think that was a big mistake. The bottom line, it's a good vaccine, but because of that buyer's remorse, because nobody was hearing about getting it, the fact that they rolled it out as a 1-dose vaccine instead of a 2-dose vaccine, when it was always a 2-dose vaccine, just like the mRNA, was always a 3-dose vaccine, that soured the public on it. And then because of the very rare serious complications, I think the message that went out was there's a problem, and so public perception was they basically voted the vaccine off the island.
Right. That's what I was going to say. You know, from the ground, when vaccinations initially rolled out, I think most healthcare professionals were recommending the mRNA vaccines. And when you had someone who said it's Johnson & Johnson or nothing, then we said, well, go get Johnson & Johnson because it had to be better than nothing. And then when we saw the severe complication and we halted for about 2 weeks or so, it was a great opportunity to tell people, okay, you know, get the mRNA. And that's pretty much the recommendation now.
So it doesn't matter if you had Johnson & Johnson, you get the Moderna or the Pfizer?
Yeah, go ahead. Get boosted.
Okay, I'll let them know. Thank you.
By the way, if anybody has questions on local, you can always email me. The anti-vaxxers have my emails. it's just Hotez, last name, at HOTEZ at BCM. It stands for Baylor College of Medicine.edu, Hotez.edu. But just put in the subject line that you're part of this, because you can imagine what my inbox is.
Well, first I'd like to invite everyone to help me thank our panelists for the As a show of our thanks for joining us this evening and for sharing such wonderful information.
That's very kind.
It's a small token of our appreciation from Emancipation Park, so you get to take a bit of us with you as you go.
That's very nice.
This series is part of Emancipation Conversations and lead up to our 150th anniversary Juneteenth celebration coming up this weekend. Is designed to be entertaining, informative, and educational, all rolled up in one, with the things that are impacting the African American community from an educational standpoint. It was important to us to touch on topics that are relevant to our community today in the spirit of what our ancestors laid before us in the legacy here of service at Emancipation Park. With that said, this program, as well as upcoming programs, will continue to touch on things that are of direct import to the African American community. For example, tomorrow evening, we invite you to join us for our discussion on social justice. We'll be featuring panelists such as P.J. Floyd, the brother of George Floyd, Dr. Howard Henderson, Dr. Whitney Threadcraft, as well as Judge China Jones. We welcome you to join us tomorrow evening for that discussion. This particular series is being live streamed and recorded on Facebook and Instagram, and you'll be able to find us on YouTube afterwards. We also have the pleasure of having ABC 13 here to record most of this session, and you'll be able to see that later on the news. I'd like to again thank our panelists, Dr. Porsa, Dr. Savage-Jeter, and Dr. Hotez for lending so much of their time and their expertise. With that, we're going to close the program for this evening. Thank you again for attending. If you haven't gotten vaccinated, go get vaccinated. If you need a booster, go get boosted and get home safely. Thank you.